Our accredited programming now continues. I'm Laura Koslow. I'm one of the board members of Aspen. I'd like to introduce our next two speakers, Jessica Monczka and Penny Allen. Jessica has been practicing as a nutrition support dietitian for 20 years. Her background includes adults, pediatrics, and NICU from critical care to the clinic. She was lucky enough to have a great mentor in the early years of her career who taught her how to write PN, and she now enjoys leading classes and workshops on PN order writing for her colleagues. Jessica resides in Colorado and spends all of her free time on outdoor adventures. Penny Allen is a registered dietitian and certified nutrition support clinician and is the National Director of Nutrition Support for Optum Infusion Pharmacy. Penny has spent most of the last 30 years in home infusion as a program director, leading teams to provide state-of-the-art care based on Aspen standards and excellence in home nutrition support. She's a certified nutrition support clinician, serves as chair of the Aspen Public Policy Committee, and is a published subject matter expert in Medicare PM Policy and other PN-related clinical topics. Her passion is improving access to quality nutrition care for all patients. Pass it over to you, Jessica.
Okay, thank you so much. I am so excited to be here. Thank you, Aspen, for inviting me to join you today. Even though we're remote, I'm happy to be virtually back in Georgia. I actually completed my internship in Augusta and I started my career in Georgia. I was just looking at my account information on the Aspen page the other day and I realized I first became an Aspen member 20 years ago next month while I was working at my first nutrition support position in Augusta. So I'm so glad to be with you guys today virtually from Colorado. So for the next half hour or so, I'm going to take us on a quick trip through time and touch on some of the highlights that we have had along the way in the nutrition support field. I think it's really important to understand and appreciate our history, and it helps us better understand what's happening today. So I want to just set the stage here at the beginning with a brief overview of the early advances in nutrition support. We've actually been accessing the GI tract by tube since the 1600s. There was a growing understanding around this time as well of blood circulation throughout the body, and this led us to start to want to try to give IV solutions. So guess what we tried to do first? Wine, ale, and opiates. Those were our initial subjects. We tried to use those infused into animals. And then, you know, in the 1700s, we moved on and we're trying to use an olive oil infusion. And we did note at that point that there were respiratory symptoms in the animals, likely from fat globules, right, reaching the lungs. So this led to our early on recognition that fat or oil could only be infused by IV if it was given in some kind of modified or special form. And it would actually be hundreds of years before we would figure out how to do that. So even though we've been accessing the GI tract by tube for a long time, we were still really focused on rectal feedings actually as the preferred method for nutrition support in those early years. And just a bit of trivia for you, in 1882, our 20th president, James Garfield, was shot, and he was given rectal feeding only for nearly 80 days before he finally succumbed to infection and probably malnutrition as well. And then what else was going on in the 1800s? Cholera. So cholera pandemics were affecting millions of people around the world, and this was a huge crisis, and this actually led to the creation of the first IV saline solution. This was the beginning of our understanding of the need to replace not only fluids but also electrolytes, you know, those salts that people were losing through this severe diarrheal illnesses. So that was a big advancement in IV as well. And then researchers along this time too were also developing direct calorimetry, and this was expanding greatly our understanding of metabolism. We learned about heat-producing values for macronutrients. So this is when we learned that you know, carbohydrates and protein have about 4 calories per gram, and fat provides about 9 calories per gram. We've known that for a really long time. And we were learning that children have higher metabolic rates than adults, and that catabolism would prevent sick patients from achieving a positive nitrogen balance. And of course, around this time, we had Harris and Benedict. They estimated the basal metabolic rate using direct calorimetry, and they came up with the first version of their equation that's still in use today. So turning to enteral formula specifically for a minute, and just kind of the evolution we've undergone there. So commercial enteral formulas were introduced right mid-1950s or so. Initially, hospitals were trying to blend their own formula, you know, to save money, of course, but they quickly realized that the staffing and time involved in doing that and the inconsistency of the product that they were coming up with, issues with viscosity of this formula they were trying to put through tubes, concerns around sanitation, et cetera, it just made sense to go ahead and purchase the commercial formulas. So commercial formulas rapidly expanded. You know, they expanded into not just our polymeric formulas, but we had partially hydrolyzed formulas. We had amino acid formulas, and then we went to, you know, hepatic and pulmonary and renal and diabetic formulas. So we kind of ran the gamut of all these different available types of formulas. And now, interestingly, you know, it's almost like we're coming full circle again, right? So in the last, I don't know, 5 years or so, we've had this resurgence of people really looking to have like a food-based formula. We kind of heard a little bit more about this earlier. So, you know, we're turning towards maybe more of a blenderized food approach, kind of back to where we started. I just think that's interesting. And then turning to parenteral for a minute. So, all right, so going back to metabolism and nutrient needs, you know, we were learning how important nutrient was for healing. It was understood. But for patients who didn't have an operational GI tract, we didn't have a lot of options. So this is Dr. Jonathan Rhodes here, namesake of our Aspen Rhodes Research Foundation. He was a surgeon in Pennsylvania at the time, and you know, their team was frustrated. They would do a perfect operation on a patient, and if the patient did not have a functioning GI tract, they would die from malnutrition. So in this country, TPN really started with this team in Pennsylvania. Dr. Rhodes was really strongly interested in this. He encouraged his trainees to pursue the IV route as a means to provide adequate nutrition to these patients. And I want to turn to Dr. Dudrick. So Dr. Dudrick is one of those trainees. For patients without a functioning GI tract, they were giving what they called the glucose program, which was 2 or 3 liters of a peripheral isotonic solution. They did not have central access. There were issues with the catheters they were using with inflammation and such, so they had to do peripheral. So they couldn't do a concentrated solution. And remember, they didn't have any safe IV fat emulsions yet to give a concentrated source of calories. So they were really stuck with these high volume solutions. So when IV diuretics became available, they could increase the volume and give even more of their glucose program. So then they changed it to be this glucose program that was called the 5-liter program. They actually gave 5 liters of like a dextrose amino acid solution. They would give this huge volume into peripheral veins and then diurese the extra fluid off each day. So I just think this stuff is so interesting. You can read about Dr. Dudrick elsewhere. There are a ton of interviews. It's always been interesting to be able to hear him speak. And he was such an outside the box thinker. He would literally let nothing stand in his way. He was a surgeon, but he was also working in the lab. He was, you know, trying out different nutrient solutions to see what would stay in solution, what would be a stable admixture without precipitating out. And remember, there was no guideline back then for him to follow, like what should he be putting in the TPN bag. He was just basically trying to mimic what he thought would be in the portal vein after someone ate a balanced meal. So once he was finally able to get a stable solution, he needed to sterilize it to make it safe for IV administration in patients. He couldn't heat sterilize it without it turning into caramel from the Maillard-Browning reaction. Hopefully that doesn't bring back a shudder of memory from chemistry class. So again, thinking outside the box, he talked with his friends and colleagues, and he found out about millipore filters that had been in use for a long time. Actually, the wine and beer industry was using them. So he used that. So now he had a stable and sterile and, you know, fairly complete for the time IV nutrient solution, but he still couldn't give it by central vein. So he was stuck with this really high volume peripheral solution they were giving. So again, he reached out to others and he just thought way outside the box this time. He talked with students in the engineering departments. He went down to the hardware store. He visited the auto parts store nearby. It's so fun to hear him to have heard him tell these stories. And he eventually came up with a central venous catheter of plastic coating tubing that would work in patients, and it was using a speedometer cable, is what I have heard, from the auto parts store that he had sterilized for use in patients. So now he has his stable solution of nutrients, he has it sterilized, he has the ability to give it by central vein. So his next step was really to prove that he could grow using this IV solution. So he worked with puppies. He wanted to see if he could grow a puppy just as well as their counterparts who were eating a normal diet. So spoiler alert, they did grow. This is a famous image that you've probably seen before. It's been on the cover of one of our Aspen journals. It's on the Aspen website now, which is where webpage now, which is where I grabbed this from. And this shows Dr. Dedrick's puppies with the TPN fed puppy having grown just as well as the normal diet puppy. So around this time, there was a baby born nearby with a congenital anomaly. She had very little functioning GI tract and she was dying of malnutrition. Her physicians had heard about what Dr. Dedrick was doing down the road with his glucose program and with the puppies, and he asked them to come and do the puppy trick on their baby. So they started the baby on TPN, and with a lot of really close monitoring, she began to grow. Even though she was growing, she had, there were issues that they figured out along the way. This was all pretty new. She started to get red, dry, flaky skin. And they realized she was deficient in fat because remember, there was no acceptable, safe IV lipid product at that point. So they had nothing they could give her. So they had her parents, they found out they had the same blood type as her. So they had her parents eat a big fatty breakfast, and then they would come in and they would have their blood drawn every day, and it would be spun down to separate out the fat content. And they would then infuse this into the baby as her fat emulsion. Pretty cool. So in 1975, 35 clinicians got together in Chicago and they founded Aspen. And Dr. Dedrick was the first Aspen president. And I just have to throw this in here for fun. This is from a 1978 feature in People magazine. And this is featuring Dr. Dedrick and his life-saving IV system. And you might be surprised to learn that just about as long as we've been using TPN, we've been sending patients home on it and they've been doing it themselves at home. So if you're interested in this, there's a really nice review of the early history of home PN in the October 2018 issue of NCP. And I just stuck a couple pictures from that issue in here for you to see. Okay, so we have now had, modern day as we know it, enteral and parenteral nutrition support for over 50 years, right? And for just as long, we've been trying to answer the questions about which is better, which is safer, when should they be started? Sometimes, honestly, it feels like a pendulum, right? Swinging back and forth through the years. And these are just a few of the trials and society guidelines and such that we've had recently to address these questions. We recognize, of course, that enteral is preferred, but we're still trying to figure out, when enteral is not feasible, or maybe we can't get all the way to the target goal that we'd like, when or if or how should we start parenteral, right? So we are kind of looking more at this idea of supplemental TPN and, if and when that belongs in the mix as well. We started off, I think, doing maybe a bad job with our TPN. We used to think that more was better. It was initially called hyperelementation, right? Hyperel or HAL, probably you've been around a little while like me, you've heard that expression before. And that just basically means giving more than what's needed. We were trying to catch them up. We were overfeeding everybody. And we were causing a lot of hyperglycemia and infections. So now that we're doing a little better job with our TPN, we're dosing more appropriately. We have better products in the marketplace that have less negative side effects. I think we're starting to maybe see the pendulum, swing back more towards a mix of enteral and maybe some supplemental parenteral in select patients where it makes sense. So I wanted to include this because I've been teaching classes and workshops through the years on TPN order writing, and one thing that participants always want as soon as they are first learning how to write TPN electrolytes is some sort of algorithm or cheat sheet, right, that tells them if the lab is this, then you should adjust the dose of that electrolyte by this much. That's what they're all looking for. So this is a paper that tried to do that. This is actually from 20 years ago. And it's interesting to look through. You've heard the expression, though, it's an art, not a science, of course. And I do think that that's true with electrolyte adjustments. If you've been writing TPN for a long time, honestly, your brain probably has this flow chart in it and runs through it without you even realizing it on every patient, every day, with every order. But you're also taking into consideration all this other stuff, right? Like you have infinite other pieces of information, like what's going on with that patient today, what's their current medical condition, what's happening with their organ function. What information did you gather during pre-rounds, and then what discussions are taking place in rounds today, and what's the plan for tomorrow, because you're always writing tomorrow's TPN. Really, it doesn't hang till tonight, right? So there's just a lot more to it, and it's really hard to use something like this to be able to tell you what the answer is for writing electrolytes. All right, so I want to try to engage you a little bit. I know we're virtual, but and so I didn't pop this up as like a polling question because I don't have a lot of time today, but just think about this. What lab provides an indicator of nutritional status? So we really like to have objective measures, right? We would love to have an objective lab that gives us the measurement of our patient's nutritional status. Use albumin, and in fact, it's still being used by insurance companies today to determine if a patient qualifies for nutrition support. Hopefully that's going to go away, but you know, it's still something that's there. And then we said, hey, albumin has a half-life of 18 days, so let's use pre-albumin. That's so much better. The half-life is only 2 days, so it's a better indicator of what's happening with our patient's nutritional status now instead of 3 weeks ago. However, both albumin and pre-albumin are really more indicators of inflammation. They decline in the presence of inflammation, and they really indicate illness more than malnutrition. And then let's see, choice C, transthyretin, is just another word for prealbumin. Did you know that prealbumin was initially given that name because it made it through electrophoresis faster than albumin? So, but another word for it is the transthyretin. I'll get better at saying it if we start using that word more than prealbumin. So we may start to see a change in terminology there. And then the last choice there is phosphorus. So that, as you know, is primarily an intracellular electrolyte. So our patient could certainly be severely malnourished, and they may show a normal serum level, right, of phosphorus, because we can't look inside the cell to see what's in there. We can only see what's in the serum. So even if the body cells were completely squeezed dry of all their phosphorus stores, we may not see that show up in the labs until we started infusing nutrition into them, right? And then that phosphorus would head out of the serum into the cells to try to rev up ATP, and the serum levels might go down very quickly, which of course we refer to as refeeding syndrome. So sorry, it's a bit of a trick here. The correct answer is none of those options. But you know, we just are really always looking for that objective laboratory measurement. So we've just always pushed for this. I wanted to mention this because there is a brand new position paper out in the October issue of NCP on this topic. So for those of you who already are thinking, as I'm talking about that one clinician who always wants to order prealbumin, this will be a good paper to tuck away in your toolbox and grab for future conversations, or maybe you could have a journal club on it or something to kind of go through that, and everybody can come to their conclusions on whether or not prealbumin is worth testing. And then I just had to include that paper on the bottom. This is from the Journal of Hospital Medicine. I love the title. They have a series called Choosing Wisely, Things We Do for No Reason. And they had a feature on prealbumin last year. So they pulled data from the Cerner database. So it was about 700 hospitals in the US that use Cerner for their electronic health record. And they looked at 2015 alone, so 1 year. They tested prealbumin levels 130,000 times. And that equated to $2.5 million that they spent on checking prealbumin, which was probably kind of useless to figure out their nutritional status. So you could actually amend this to say expensive things we do for no reason. Let's stay in the theme of labs for a minute, but then move on to trace elements. So to go along with the last slide and things we do for no reason, I'd like to maybe think about filing this under the category of things we've been waiting a long time for. So we've known for a really long time that the doses in our commercially available multi-trace element products were not great, right? In 2009, Aspen had a 2-day pre-conference research workshop. I was actually lucky enough to attend it, and I still, to this day, say that that was, you know, my favorite presentations I have ever attended. It was 2 full days before the conference. But it was so good. Every hour was a new micronutrient, and it was presented by like a world-renowned expert speaker. The findings from that workshop were published. Each micronutrient had its own paper in gastroenterology, and then that position paper came out in 2012 with the summary of recommendations for the changes to the commercially available multivitamin and multi-trace products. So that was back in 2012. Here we are in 2020, and we are finally starting to see, over the past year, we've had FDA-approved individual selenium and zinc products introduced. And now, just as of last month, we have a brand new multi-trace product that matches these consensus recommendations. So that's really exciting. If you haven't seen that product yet, you will soon. It's probably, they're just using up the old and moving on to the new. Okay, I promise you I'm not going to talk about drug shortages, but I just couldn't have this talk without at least including a slide about it, right? Because we just have to acknowledge that this is definitely one of the huge topics that we've been dealing with for so many years. So I guess I would file this one under things we've been dealing with a long time and would really like them to go away, but they don't. We do have great resources to help us. The Aspen page has a lot of information, and ASHP has continually updated information to help us navigate our world of never-ending drug shortages. So let's have another learning assessment question. Again, just kind of think about this for a minute on your own. What is the most common sign of EN intolerance that nurses report using before they decide to hold feeds? So surveys have reported that more than 97% of nurses assess tolerance solely based on measuring gastric residual volumes. And they usually report that they will hold feeds for 200 or 250 mLs. So if you're looking at this question like, well, we're not supposed to be doing that anymore, we shouldn't be looking at gastric residual volumes, you'll get a different answer. But the question's actually asking what are nurses reporting that they're using? And the answer is still today, gastric residual volume. So even though they'll even comment on the survey, they'll say, I know this isn't part of the guidelines, I know that this isn't what we're required to do and it's not ordered, but I still want to do it. So I guess it's kind of like us still checking pre-albumins all the time. So we really like to have those objective measurements, right? We want to have like a number that tells us, is our patient tolerating our feeds or not? And we use these arbitrary numbers, 1.5 times the flow rate, 2 times the flow rate, 100, 200, whatever. So this paper declaring that holding enteral nutrition for a high gastric residual volume may not be physiologically sound is actually from 1997. I don't know if you can see that or not. This is not a new controversy. Studies have shown that eliminating gastric residual volumes improve delivery of enteral. We know that, and it's not a concern for patient safety. We know that gastric residual volumes don't correlate with incidences of vomiting, aspiration, or pneumonia. And we know that when we check gastric residual volumes, it leads to more clogging of the tubes. It leads to inappropriate holding of the enteral nutrition. And it's more nursing time and staff time and resources. But we are still doing it, as you can see from just a few survey comments I added there. And this is just the 2016 Aspen SCCM critical care guidelines. They addressed this as well, and they suggested, first of all, that it shouldn't be used. And second of all, if it truly must be used, let's go with 500 mLs before intervening. And it's, it's still not being followed. So this is just an example where we don't always do what the data and guidelines tell us to do, or we may come out with these clear guidelines, but they don't make it all the way down to the bedside and the patient, right? We have these great guidelines, but how do we disseminate these society guidelines to all of our hospital systems and all clinicians who aren't attending these kind of conferences? How do we make sure this published best practice reaches all of our patients? I don't know the answer to that. Okay, another big shift in practice that's happened in the last 20 years. From the early days, we were using a lot of glucose, right? We had the glucose system, we didn't have lipids for a long time, and we thought glucose was relatively harmless compared to the pro-inflammatory fat emulsions. We also still often followed that more is better approach. We loved our hyperelementation, right? We were overfeeding everybody. So this 2001 Vandenberg paper was a really big wake-up call. Prior to this, those of you who are practicing, you probably will agree with me here. We had been okay with blood glucose levels. I mean, I could say into the 200s, but I almost want to say into the upper 200s. Like we didn't want our patients on TPN to have low glucoses, but we weren't really that worried about them going high, to be honest. So this study was a wake-up call. It compared type glycemic control, so their target was less than 110, with a more standard approach, 180 to 200. And they showed a very significant 34% reduction in hospital mortality with that tight glucose control. So this really set off a flurry of activity. More studies, a hard look at institutional practice and a big change in behavior, I think, for those of us who were writing TPN. We started to pay a lot more attention to those glucose levels. And then we had more studies come out, so we had these guidelines to maintain tight control, and then we had some other studies that showed that maybe tight control wasn't the best, and maybe mortality was actually higher in those groups. So eventually the 2013 Aspen guidelines came out and said that for critically ill patients, we should go for a target glucose range a bit higher. They went with 140 to 180. So the pendulum, again, on this topic kind of swings back and forth. Okay, bear with me because some of you might not find filters that interesting, but I think they're actually kind of fascinating. I'm always interested to read about this. So we've had our recommendations for filtering now for quite a few years, and we have our two different sizes that we use for TPN, right? We have the 0.22 micron for our 2-in-1 bags, and then we have the larger 1.2 micron for our 3-in-1 bags that have lipids, because lipids can't make it through those small filters. So it's always been a little bit confusing, especially working in home infusion. If patients are getting 3 days a week lipid bags and then the other 4 days are what we call the clear bags, do you send them to different filter sizes, to make sure you're covering all your bases and getting all the bacteria or anything you could get out? So Aspen has just come out with a brand new position paper on this as well. So they looked through, and said, based on the best available evidence we have, probably using a 1.2 for everything is okay. They think, the most dangerous things are particles greater than 2 microns, which would be caught with those larger size filters. So to avoid the risk of, adverse consequences and confusion and all of those things, maybe just doing the one filter is okay. So I thought this was an interesting read. I just wanted to throw it up there. If you're interested in this topic, it's kind of, it goes through the history of filters and what they catch and all of that stuff. So I would recommend it. And then I thought I would finish up by mentioning the advance that probably you would all think of first when you're thinking of advances in the last few years, right? We're all talking about this and excited about this. I mentioned earlier how Dr. Dudrick and his colleagues back in the 1960s had the parents of that first little baby eat the fatty breakfast and they would spin down their blood, and that's what they were using for the lipid emulsion. We did actually have a lipid emulsion before that in this country. It was a cottonseed oil emulsion. It was released in 1955. But it was associated with serious reactions and it was withdrawn from the market after several years. So since they didn't have that IV lipid source available for those early patients, Dr. Dudrick and his colleagues, like I said, were working with what they were calling the glucose system. So across the pond in Sweden, this was Arvid Retmund here with Dr. Dudrick. They were working with they created an emulsion of a soybean oil with egg yolk phospholipids used as an emulsifier. And this was approved for clinical use in Sweden in 1961. The Swedish IV feeding regimen was being called the FAT system. So they were kind of doing their two different versions of those early days of TPN. They were providing like half the calories as fat. Because we had those negative experiences with lipids in this country, the FDA was really reluctant to approve another fat emulsion. So it was another 15 years before that European soybean oil emulsion was approved for use in the US. That was 1975. And now 40 years later, we're finally starting to get a good variety of lipid emulsions in our commercial marketplace, which is so exciting. So you've probably seen this chart or something similar. This one in particular is from the new Aspen Lipid Injectable Emulsion Safety Recommendations paper, which was just published in NCP as well. Okay, so that was quick. We covered the highlights of the development of enteral and parenteral, what some of the major advances and controversies have been in the years since. There's so many more topics to cover. These are just a few of what I had come up with as I was thinking about what I wanted to cover today, and I really just had to pick a few with not much time. But one of the overriding themes, I think, definitely has been like the shifts in thinking, that pendulum kind of swinging back and forth, sometimes all the way from one end of the spectrum to the other, which I just think is so interesting. Is the gastric or post-pyloric route preferred for enteral? What is the optimal and safe target for glucose control? Which combination of lipid sources are the most beneficial? When is it safe to feed a hemodynamically unstable patient? Should we permissively underfeed our critically ill obese patients? Should we dose based on protein instead of calories? What types of antioxidants and micronutrients are beneficial? What dose? What formulation type? There are so many questions left to answer. I really just think it's helpful to take this time to look back at where we've been, understand the history and our advancements that we've made in order to better understand the research as it comes out and understand our clinical directions going forward. So thank you for joining me today on this brief little trip through time. And now I have the honor of passing the controls over to our amazing colleague, Penny Allen.
Hey, good afternoon, everybody, and thank you so much for having me. Wow, that was a great talk, Jessica. You fit an awful lot into 30 minutes, and I just love some of the things that will actually translate to our update on public policy today. But the one thing I think I'm going to take away, I love the notion of things we do for no reason. Being in home care for the last 30 years, I think we could have a David Letterman top 10 or even top 20 of things over the years that people want to do for no logical or scientific reason. So thank you for that great talk. My name is Penny Allen. For those of you that know me, I'm the National Director for Nutrition Support for Optum Infusion Pharmacy. I'm also honored to serve as the chair for the Aspen Public Policy Committee. I'm in my second year of a third-year term, and hopefully today I'll give you a little taste of what public policy is all about. So hopefully I can whet your appetite and engage you to get involved with public policy efforts. I have nothing to disclose other than my employment. All right, so upon completion of this talk, hopefully you will understand the mission of the Aspen Public Policy Committee, list a couple of priorities, 2 or 3 for the Public Policy Committee in 2020, and then at least be able to state or identify 2 resources that are available for all clinicians who'd like to get involved in public policy. Okay, so the American Society for Parenteral and Enteral Nutrition, this is our mission. The Public Policy Committee, we seek an environment in which every patient receives safe, efficacious, and high quality care by advancing the science and practice of nutrition, clinical nutrition and metabolism. All right, the goals of advocacy, and then we'll get into some of our initiatives and what's going on this year, but we're really here to advocate on behalf of the field of clinician to drive improvements in performance and patient outcomes. Our scope includes looking at high priority issues pertaining to nutrition support, and Jessica mentioned some of them. The drug shortages issues. Our advocacy allows us to work with other entities, basically working with government, Congress, the executive branches, regulatory agencies like the FDA, CMS, the Centers for Medicare and Medicaid Services, et cetera, et cetera. We also join other coalitions and other organizations, since we're Aspen as a whole is a pretty small organization, relatively speaking. So when it makes sense, we join forces with groups like the Oli Foundation, the National Home Infusion Association, Digestive Disease National Coalition. So we work with a lot of groups to help attain the goals of our organization. So in our overall objectives, improving the quality and safety of nutrition for all patients and consumers, advocating for fair reimbursement to ensure that beneficiaries of government-funded entities and programs receive the highest quality nutrition care, and then sponsoring the concept of a fair marketplace that doesn't jeopardize access, safety, and so on and so forth in terms of pursuing quality nutrition support for all that need it. This is just a little bit of background in history to give you the flavor of what Aspen has been involved with in the past. Overall, that overarching advancement of clinical practice, setting the standards on a national level for, interdisciplinary clinicians, dietitians, pharmacists, nurses, physicians, really setting the standards for hospitalized care as well as home care, and being able to work with the NIH. They historically have been the largest supporter of nutrition resource. So Aspen, as you well know, if you've been, a clinician involved in nutrition support for a short time or a very long time, you know that a lot of the research scholarships and the funding, fundraising, everything that we do is to be able to contribute to supporting research to advance our practice. And in the past, we worked directly with the NIH when there were clinical nutrition research units that helped advance the practice. Reimbursement has been a big focus for a number of years. You know, appropriate payment for nutrition therapy across all healthcare environments. We've done a lot of work with different bills and so forth that try to establish, you know, differentiation between enteral nutrition and parental nutrition from foods and other basic types of nutrition. There are many lay people, you know, that work in government and other organizations that might not necessarily understand the differentiation between high-tech nutrition support care and other means of basic nutrition. You know, professional services, you know, how do we get paid? Who gets paid for what? What's a reasonable amount of payment? What about competency? Who's competent to be able to provide nutrition support education and so on? One of the earliest bills that Aspen got involved with was the Medicare Medical Nutrition Therapy Act of 1999. And this was basically the beginning of getting CMS to pay for nutrition counseling for patients with diabetes and renal failure who were Medicare beneficiaries. Prior to that, there was absolutely no reimbursement whatsoever, no acknowledgement for nutrition consultation, diet education, et cetera, for any disease state. When we get to a little bit later in the talk, one of the bills that we've been working on for the last year or two has been the updated version of the Medicare Medical Nutrition Therapy Act, and trying to get them to expand the scope so that there would be reimbursement for nutrition counseling for other disease states beyond diabetes and renal failure. Again, looking at, you know, what criteria needs to be in place, you know, establishing if someone is going to be able to bill for their services and provide that counseling, what competencies do they need to meet? And is there any type of gatekeeper, you know, type of mentality involved? Meaning, you know, do you need a physician referral? It's not just open to anybody and everybody. The physician has to make a referral. Food and Drug Administration. Historically, Aspen has worked with Food and Drug for years. As Jessica mentioned, drug shortages have plagued the home parental nutrition and the hospital parental nutrition markets for 3 decades. I remember the very first multivitamin shortage. I can't remember what year it is. It was probably in the early to mid 90s, where we had to import a multivitamin from Canada. So since that time, I mean, it's literally been 3 decades of off again, on again, that pendulum, just in a different way of, you know, what do we have, what don't we have? This manufacturer's lines got shut down. There were hurricanes in Puerto Rico. We don't have amino acids. We don't have premixed. I mean, we've lived through very, very challenging times. So in terms of patient safety, I mean, Aspen and many other organizations have worked with the Food and Drug, and as recently as this Tuesday, as part of Aspen and the Healthcare Nutrition Council, we actually had a call with the FDA on Tuesday to discuss unintended consequences of this Unapproved Drug Initiative Act, and I'll speak more to that in a little bit. Safety issues are big, you know, going back all the way to safety alerts for lipids and so forth. So we've had a long-standing relationship with the Food and Drug Administration. This past Tuesday was actually my first experience being on a call with them, along with many other subject matter experts like Jay Murtalo, Peggy Gunter. And it was really interesting to see the collegial relationship that they all had from years of working with some of these folks from the Food and Drug, and how much respect there was for Aspen. Regulation of medical foods and being able to designate which products serve as medical foods. So there's a lot involved with the FDA. So I'll stop and just ask a quick question, but I already gave you the answer on the slide. Which 3 areas of focus on nutrition support is Aspen Advocacy involved with? I gave you a little hint, the 3 R's: research, reimbursement, and regulations. And if you think about it, depending on what your scope of practice is, this impacts all of us in some way, shape, or form. You may not think it if you're working in a hospital and you have a really defined scope of practice, whether it be pharmacy, nutrition, nursing, but directly or indirectly, there is definitely research impacts what we do, what new products can come out, you know, when we run out of a certain lipid or a product, or, you know, something new is coming on the market, you have research to thank for that. reimbursement is huge, whether you work in a hospital or the home care setting, you know, having patients be allowed to have the therapy that they need, and that, you know, setting the fact that is reimbursement appropriate for that? Do they even have coverage for it? I'll get on my soapbox about Medicare PM and EN in a few minutes, but, you know, the numbers of patients over the years that have not been allowed to have PN and EN at home because of outdated regulations. That's moving to the next one. It's tied in with reimbursement, but it's government regulations, whether it be state, federal, have definitely impacted whether patients and consumers have access to care. So we've spent a lot of time and energy in that arena. A couple of other things, you know, obviously I mentioned we serve as a resource. Aspen is highly respected as the clinical resource. You know, we don't have an agenda for financial reasons, or, you know, and a lot of times that's where we can make a major difference. We're respected for being the clinical experts, the safety experts when it comes to parental and enteral nutrition. So working with the Centers for Medicare and Medicaid Services and the 4 carriers that administer this is huge when we talk about access, regulations, changing outdated policies, and we'll speak more about that. Providing clinical advice to the FDA on medical foods, access devices, you know, recalls. We just recently had a recall of a pump that was very commonly used in the home care setting. So we're, you know, strongly involved with that. And drug shortages, again, that's just been a given, unfortunately, as the years have gone by. Aspen Public Policy monitors activity in Congress as it pertains to home health care, technology, professional involvement, anything really that impacts us. It's interesting, you know, I've come to learn that we get reached out to quite a bit by other organizations asking us to sign on to a piece of legislation. It may not be directly involved in what Aspen does, but we take a step back, we look at it, and we say, is this something that it would make sense for us to be signing on for? And then we're advocating, you know, whenever there's something within the government, overall health assessments of the population, and so on and so forth. And that would be an example of if someone reached out to us and said, hey, do you want to sign on to this? Do you want to join this coalition for whatever reason? It's looking at health issues, population issues, disease state issues in the United States. Certainly we would get involved. So our overall goal is, and this is kind of duplicative, but serving as a responsible voice for nutrition support to inform and influence policymakers, payers, healthcare organizations, and accrediting bodies like Joint Commission, ACHC, etc. I'm not going to read so much of this. I think that I've kind of touched on it. You will have the copies of the slides, but you know, if you think about even at the end of her last slide, there's so many things for us to get involved with. On public policy, topics like the NFIT connectors come up. There's, you know, controversy or dissent about, what are we doing? Should this be applied across the board? Some surgeons say that there's difficulty because they can't always place them. On and on and on. Electronic orders, electronic medical records, billing codes. You know, recently we signed onto something in the last year that was trying to update the ICD-10 codes and the definitions for short bowel syndrome. So there's really just a wide variety of things that we get involved with. And I will tell you, this has probably been one of the best learning experiences of my career, to be involved with public policy. I will say, you're probably thinking to yourself, much like I did years ago, like, I don't know anything about that. I'm kind of afraid of that. That's kind of oh boy, I don't think I could do that. And somehow, some way, I ended up on the committee, and the joke on the committee, one of the former leaders used to say, once you get on public policy, it's like the Hotel California, you can never leave. So it really is an interesting committee to be on, because you learn a lot, and it really takes a little while to feel somewhat comfortable with, like, what are we supposed to be doing here? But anyways, let me give you a great example of how sometimes at the end of the day, you plug away and plug away and plug away, and you finally get something to happen, and that's like incredibly exciting. So objectives, again, kind of the same language, but it really is across the board advocating for nutrition support, regardless, home care, hospital, across changing reimbursement paradigms, advocating for needed products. Part of our conversation Tuesday with the FDA was, hey, there's a lot of other products in the rest of the world for PN. They've been out there forever. The Europeans or South Americans or Asians, these studies have all been done. Why can't we allow them into the United States? Why do we have to have such a precarious supply chain of materials that we only have one trace element solution, one, whatever, multivitamin product, or maybe two? Because if something happens with that manufacturer, we're out of luck. So that was part of our big push. Like, let's take a look at what's going on. Let's take a look at what you're requiring for research to allow needed products, so we have more than one product out there, one electrolyte, to meet the needs of the whole United States. And can we do that from a safety and quality perspective? Research is huge. We ongoing, have a strong need for research in the world of nutrition. I think that, as Jessica said, the different mentalities flip back and forth over the years, and that'll be the flavor of the day for a couple of years. And then someone comes out with a new study and it's like, oh, okay, we're going this way now. So, we have to keep doing the research. This is how we learn. TPN, when you look at the history, was really only invented 1967. That wasn't that long ago. The first home care patients went home in like late 80s, mid to late 80s, even early 90s. So it hasn't been around that long, and we've learned by doing over the years. So interdisciplinary approach, that's a given, and then adequate funding. I'm gonna basically point out to you that this is new for the Aspen Policy Committee, that if you go to the Aspen homepage and you click on Public Policy, you will now see a tab that says Resources. You would be able to click on some policy primers, public policy primers, so that if someone new joins our committee, and this year's been we've had 2 meetings thus far this year, and we do have a number of new members on public policy, which is awesome. It's nice to get fresh new perspective. But again, I think this is the kind of committee that some people say, like, well, I don't know anything about that. I don't really think I'd have anything to offer. And we kind of actually corralled a couple of people to offer up to be on the committee. But these new primers that Jay Murtalo put together, it's really meant to be an introduction and share with you, and some of the slides that I just presented are from these primers, that this isn't that hard. This is what we've done. It takes a village. So starting right out of the gate, instead of it taking a year or 2 years or 3 years for people to feel comfortable, we've now introduced some primers so that hopefully people can dive right in, get a feel for what advocacy is about, understand what they can do to help, and so on and so forth. So this is exactly what I was talking about. Here's a screenshot. One of our questions, where would you find Aspen Public Policy primers and other resources if you wanted to get more involved with advocacy? And this is exactly where it is. All right, I'm not going to go into this, but on the website, you'll also see all these different federal government agencies and websites in case you ever wanted to know or wanted a nice, quick, and easy link to them. This is just a snapshot of a very few bills that we are monitoring, supporting, involved in. And when we have a meeting, we're just discussing, where is this at? We do get information from the DDNC, which is the Digestive Disease National Coalition. We usually get regular updates from them about what is going on in the House and Senate. And I will tell you, DDNC once a year has like a day on the Hill. It's in March, first weekend of March every year. And Aspen usually sends at least 2 to 3 representatives to attend. And again, it's one of those things that you think, oh my God, I can't do that. That's really scary. I've never been to Washington, DC before. I'm not going to know what to do. What do I say? And I've been twice now. And after the first time I went, I was like, oh my goodness, that was incredible. That was so interesting and different, and people help you. And it's, you go through and you go to the senator's offices, you get divvied up into teams, you go to the House, you go to the state reps, you go to your own, you get assigned by what state you are, and you have a defined agenda of what bills you're there to represent and talk about. And it is, I came back and I said, I want to go every year. I mean, it was really an incredible experience. So, again, I'm kind of doing a recruitment ad for all of you. There was a paper that summarizes what our efforts were to date, and this was published in NCP March 2018. If you want a good little overview of what our efforts have been historically in regards to home parental nutrition reimbursement, particularly with Medicare, and what Aspen Public Policy has done over the years, this is a good review paper that not only outlines what public policy has done, it kind of outlined the outdated, crazy PN policy that we've all had to live with for the last 3 decades or so. And I am incredibly thrilled and honored to report that after greater than 3 decades, we finally have a change in the policy. I will set the preface by saying it's not perfect. It's not exactly what we asked for by any stretch of the imagination, but for the first time in many, many years, and as Laura said, I've been in home infusion since 1989. And since that time, people have said, hey, do you think the Medicare PM policy is going to change? A lot of patients don't meet this policy. And we've said, like, well, of course it has to. Well, you know, here we are up until November 12th, 2020. You know, this summer, I had the pleasure of meeting with the CNS, the 4 DME MAC medical directors, along with Bill Noyes from the National Home Infusion Association. We actually had been working together and even in concert with the Oli Foundation to say, you know what, it's time to give it a go again. We've tried this a number of times. The last time was in 2014. Let's see if we can pull a committee together, and thankfully we pulled 3 other experts from home infusion to help do the research, look at what the current policy was, you know, at least ask for some changes. What I've learned over the years is that in order to get something, this is law, so to get it changed, you need to draft a bill, it needs to pass the House and Senate, and that literally can be a 10-year-long process if you're successful, or more. So the easiest path was, all right, it's an election year. Let's see if we can file what's called a reconsideration. We'll go in there with a document. We'll do a scan of the research again. We'll do evidence-based medicine, you know, give them some other suggestions and ask them to throw out crazy things like a fecal fat study, a failed tube feeding trial for somebody that has a partial obstruction due to cancer, et cetera, et cetera. Well, we met with them in July. They were incredibly receptive. They said, stay tuned in the next couple of months. And we were like, yeah, right, okay. And then October 8th, out of the clear blue sky, they post on their website that they are retiring the parental and enteral nutrition coverage determinations, LCDs, local coverage determinations, which is actually the law, as of 11/12, which was yesterday, and where this is the beginning of us still plugging forward, but the policy for EN and PN will still live under prosthetic device. So we're not there yet. That long-term need for therapy mentality is still there, but we're defaulting now to what always existed, which who knew, called the National Coverage Determination, or NCD. And if you want to listen in a little bit more, go to the Aspen homepage, and there's a webinar on all of this. There's actually a podcast that we taped last week that just got loaded yesterday, and this will give you much more detailed information. But to say that I'm like over the moon that they made any change whatsoever is good. When you read that National Coverage Determination, don't freak out. There's a lot of really old language in it. It was written in '84. So in combination with Oli, NHIA, and Aspen, we are still in communications and will continue to be, to ask CMS if we can help them update it. They've told us to just basically disregard some of the outdated things. And here's one of the things I love. When Jessica had the slide of showing that people used to make their own PN, that big table with the dextrose, the amino acids and everything, the language in the National Coverage Determination actually still calls, there are still B codes for home mix. Nobody today should be using those B codes. I haven't heard of anybody doing home mix, and that's what they mean, since literally the 1980s. So it's got to be updated. When they talk about premix codes, that doesn't mean Clinomix or Cabiven. That means compounded PN. So this is outdated language, verbiage to a degree. It needs to be updated, and we're still moving ahead. But this is what the items look like. All of this information is on the Aspen website. But I will tell you, after all of these years to at least get some kind of change without all that crazy testing that was Things we do for no reason. How about a fecal fat test? You know, that takes 3 days to collect someone's stool. Just a failed tube feeding trial when you know there's no way you can put a tube down a patient. That's just crazy, unsafe, and expensive things we were doing for no reason to meet the Medicare criteria. So anyways, why would you want to get involved with nutrition advocacy efforts? If I haven't enticed you, I'm not doing a good job, but basically to just get involved in the field of nutrition support and work for, you know, the end goal of assuring that patients will have what they need. If they're on PN, that we will at least be able to have the nutrients and ingredients that need to go into that bag. For enteral, that it's, you know, that it's the right fit and we don't have sentinel events because of connectors and things like that. To promote more education and research, training in the field of nutrition for physicians and other healthcare professionals, and on and on and on. There's just lots of good reasons. So that's all I have. My time is up. Thank you so much for dialing in, and I look forward to working with you at some point in time, if I'm not already, in the field of advocacy for nutrition support. So thank you very much.
Thank you, Penny and Jessica. Great presentations. We will now open it up for questions and answer session, Q&A session. If you've not submitted your questions yet, please do so at this time. All right, I'm not seeing any questions coming over. So we'll go ahead then, and we will have a break from our accredited programming to hear a word from one of our gold exhibitors.